Welcome back to another episode of BackTable OBGYN. I've got with me once again Dr. Amy Park. Amy, how are you today?
Great. How are you, Mark?
I'm good. And we have our first repeat guest. Very exciting. Once again, Dr. Barbara Levy, good friend and colleague of ours, clinical professor of OBGYN at the George Washington University School of Medicine and Health Sciences, voluntary clinical professor, UCSD, Department of OBGYN, of Obstetrics, Gynecology, and Reproductive Sciences. That's a mouthful. Barb, how are you?
I am great. How are you?
I'm good, and welcome back.
Thank you.
Can you just discuss the practice expense as it because we've talked about facility and non-facility, but how about with specialty? Does it vary?
So it does vary by specialty. So there are direct expenses and then there are indirect expenses. And the indirect expenses are geographically different. So rent in Kentucky is going to be different than rent in New York City. Clinical staff salaries are going to be different in different parts of the country. So CMS has this incredibly difficult calculus for the indirect practice expenses, and they are adjusted by specialty depending on how much equipment and staff typically are needed in a practice. So for us, we typically will own a colposcope, a hysteroscope. If we're an independent practice, we have exam tables, we have certain things that we all use. We don't use anywhere near as much super expensive equipment as an ophthalmologist in their offices or a urologist who have a lot of these tools for managing benign prostatic hypertrophy. So the indirect practice expenses do vary by specialty. AMA this year is doing a new survey of costs and equipment and all of those things. So hopefully that will get updated. But it's the indirect expenses that really make the biggest difference across specialties.
Those surveys are such a point of contention because I feel like people undervalue their work all the time. People are undercoding. I would say undercoding is fraud, just like overcoding is fraud. And undervaluing your work is also like, what are you doing? You know?
I could not agree more. It's the hardest thing on earth to have all this knowledge. And Mark, you've got it now too, and trying to help our colleagues. So we're not allowed to coach people in survey completion. Like we're not allowed to reach out to them and tell them, hey, this really matters. So we try to do it generally and say to people, hey, look, the results of this survey make up the inputs for your work RVUs.
And a big example was laparoscopic hysterectomy, right? So it's initially valued based on surveys when people weren't doing a ton. And part of the value of a procedure is time and intensity intra-op, but also how many nights in the hospital. And so if someone's going to be in the hospital for 2 days, you get 2 outpatient, basically days of service that are added on to the procedure. So that's why abdominal hysterectomy is valued more than vaginal hysterectomy is valued more than laparoscopic hysterectomy, not just the procedure itself, but also the inpatient days on average. And what happened was they initially valued the laparoscopic hysterectomy, and we said we'll give them a couple days in the hospital, and then they resurveyed. All new codes get a reflexive resurvey at 5 years, Barb?
Yeah, it's 3 years of data, so it ends up being at about 5 years.
And so they resurveyed, and all of us, the AGL people are like, oh man, I can do a TLH in 45 minutes, and they go home the same day, and we're going, no, shut up, don't say that. You can't coach them.
Oh, I know.
So the value went down because they were resurveyed, and they said, oh, but people love to say how fast they are. It's like, no, just tell the truth. Don't lie that it takes longer, but just don't tell us your fastest one. Tell us the average, because in and
it's not even average, it's typical.
Typical, right. Thank you.
I talk to my anesthesia colleagues all the time about this. Like, surgeons underestimate their operating room time, EBL, overestimate their volume, all this stuff. Like, I remember when I first started here, and that this is not to brag, but I'm very accurate on my times. And they were surprised because I am so unusual. They said that, like, when I first started, I'd be like, okay, another half hour, because I'd be starting on the posterior repair out of the, extravaganza that I'm doing. And you could tell that the anesthesia staff was like, because they're lied to constantly. People.
Well, that's true. But when you looked at RUC surveys and you compare them, and some outside economists have done this and compared them to like NSQIP, the National Surgical Quality Improvement Project, where they actually collect anesthesia reported times, they claim that surgeons are overestimating how much time it takes us. So when you look at some data sets, and of course the NSQIP is not a reliable data set because hospitals have to pay money to participate in it. So you have to be at a certain level of a hospital with a certain amount of staff. And so it's not reliable. It's not valid, but there are people who argue that it is. It isn't. Nevertheless, estimating things plus or minus is a challenge for sure. But then what happens is those recommendations go to the table, and there's an anesthesiologist at the table at the RUC, and there's a general surgeon, and there's an ENT, and there's an ophthalmologist, and they all have friends. And the way the members of the RUC do their work is they talk to their friends, and they say, is this a reasonable recommendation? Does this make sense to you? Or they look at their OR schedule in their hospital, and they look at things. And so the survey results are then sent to this committee that adjudicates the recommendations and puts everything into a relative scale. I mean, that's what this is. So compared to a lap chole, what is a lap hysterectomy? Is it more work? Is it less work? And that's what the RUC's work is. It's really hard work. It is really, really difficult because it is just, how many 99215s, how many office visits equals an open heart surgery. That's a really hard decision to make. And people spend years. Yeah.
One other big piece of that, and again, this is all written into federal law. So one of the big pieces of this that is hard for people to understand is that it has to be, in a sense, net neutral, meaning if we're going to change a code, we're not going to get more money for those procedures. We just have to change how it's divided up, right, Barb?
Yes. So the only way the dollars change is if the patient population has dramatically changed or there's new technology. So there's new money in Medicare for new technology or more patients. But if you have an old procedure, let's say hysterectomy, and Medicare has paid, let's just say, $1 million in 2023 for hysterectomy, they're going to pay $1 million in 2025, regardless of how we reallocate those. So if some codes go up, others will go down, and it will depend on their relative volumes. But if you get paid more, and this, the very serious and problematic codes were the endometriosis codes that we were talking about over and over and over again. But there's a fixed amount of money that was put into those codes, fixed amount of RVUs, if you will. And so now if you build new codes, but they're still taking care of the same medical problem, then the total number of dollars that will go in or the total number of RVUs will stay the same.
That was eye-opening to me with the endometriosis codes because we did some of that work together. And what I think people failed to understand, there was a lot of animosity, a lot of frustration, especially from AGL, but it came from a lack of understanding of how the system worked. A lot of that ire was directed towards Barb and me as chair of the committee at the time, so I took that pretty personally. But when you have, let's say, and this is not the accurate numbers, but for the sake of the conversation, if a laparoscopic resection of endometriosis is 10 RVUs, okay, and we do 100 of them a year, then that's $10,000 they're going to pay for, or $1,000 going to pay for endometriosis for the whole year. If we want to blow it up and say stage 4 is really hard, stage 1 is super easy, I want to get paid more for stage 4. Well, fine. Most of us are doing a little bit of stage 4, a little more stage 3, a lot more stage 2 and stage 1. Now, say we get 20 RVUs for stage 4, all of those ones we were getting 10 RVUs for stage 1 for a little resection of the one blip that we saw. Now we'll get like 1 for that. So the vast majority of OBGYNs and even MIG surgeons are doing a lot of, resection of stage 1 endo, or stage 2 endo, and getting paid on average how endo should be paid. So some are easy, some are hard, which I've only heard Barb say about 4,000 times. You sort of get paid for an average, right? If you're only doing stage 4 endo, that's a frustrating system for you. If you're the average MIG surgeon who does all of it, it makes more sense. And so the whole code system blows up when you want to add new codes. Old code goes away, dollars don't change, and it really impacts how everybody's getting paid. So there's a lot at stake.
Let me explain that let's say we created new codes for endometriosis. CMS's rule is we have to resurvey the entire family of codes that serve endometriosis. So it's not like we just get to have the new ones. We have to survey all of them. And then there's that budget neutrality adjustment that is made to all of them.
So it becomes a Pandora's box. You have to be really careful. If you want to open up these codes, you are risking revaluing them and revaluing them lower than you had before. And at that point, there's nothing you can do about it. So if you got a relatively well-valued code, leave it alone.
So I want to go to something more positive.
Yes.
Because that's a real downer.
No, but I think
it's reality.
But it provides a background.
But it's a real downer.
But I think it provides a background of like the landscape of how the system works, which I think most of us just don't know.
Well, it's also strategy, and what you're talking about is the average practice or so it makes a lot of sense when you explain it. And I'm really glad that we are talking about it, because I'm actually very, very interested in coding. And, it's like an art and a science, because it's not like for, Urogyn, we like total couple places. You can code it in a couple different ways, and there's a certain way you can code it that's anterior, posterior repair, partial colpectomy. And it's different reimbursement that results in about $1,000 difference in than whatever the other code that my colleague was using. And it's not like one is like wrong and the other one is right. It's just you can use a different combo of codes,
It's really what drove the valuation of those codes in the beginning. So it's a description of who the typical patient is and what the typical procedure is. And colpoclysis in the old days was a different procedure than it is now. I mean, it was really quick and it was for super sick patients. And, it was honestly, a different procedure than what you're describing, which is a lot more work.
I don't know what it was like in the old days, but it's a very different, so anyway, there's a lot of stuff that goes into it, but I do appreciate hearing about how the sausage is made, because I think it makes a lot of sense in terms of like preservation.
And really know how hard the members, people devote weeks of their lives every year to supporting, and for decades. I've been doing this now for almost 30 years.
Wow.
A little bit more than 30 years, because I've been on the panel CPT for 8 years now.
And I had to dial it back. I had very, very strong support from Barb and from others on the committee who really advocated for me and supported me. But I was going to 8 meetings a year. It was too much. I had little kids. I was clerkship director. I was going to AGL. It was like something had to give. And it was one of the hardest things I had to do is say, guys, I can't do it anymore. But to think that others like you guys have been doing this the entire time. Going to like 2 check meetings, going to 3 CPT meetings, going to the RUC meeting. That's every year on top of all the other stuff. And like the other part about the CPT meeting, which is great, is you don't know when your code's going to go. So you have to be there for 3 days listening to people talk about new ways to remove earwax until like you get to present your code. It's a boatload of work, and it's not something a novice can just pop in and they're due. I mean, the institutional memory in that room is unreal.
So do you, like, if you opened up the endometriosis codes, would that also affect like hysterectomy codes, or would it affect like urogyne codes? It would only
No.
affect that diagnosis suite.
It's a particular family, and
Okay.
it depends on how the RUC and the Specialty Society and CMS come together and agree on what codes constitute a family. So I want to talk a little bit about site of service, because that's a good news thing for your listeners to understand that when a procedure is done in your office, you are getting credit for your space, your rent, your staff, your equipment. And so when we look at things like hysteroscopy in the office, or we look at LEAP in the office, that practice expense increment is substantial. And so for the same, your work RVUs are identical. But if you think about the time you spend writing an HMP, going to a surgery center, doing the procedure, coming back to your office, the efficiency of doing things in your office is much, much better. And you're getting some payment to cover your overhead in the office.
And when you say you, so that's we have to be specific about that. So if you own your practice in the building, if you own your practice, then you get to collect the facilities fees associated with that procedure, correct?
Well, there is no facility fee. So if you are an independent practice, it's an outpatient, office-based procedure. So it's a single code, a single payment. There's no separate facility fee in the office.
Whereas in the hospital, it's the RVU, the work RVU, the physician is supposed to be getting the value for that, and then there is a facility fee that goes
Correct
to the hospital, right? So how's that determined?
Yes. So hospital facility fees are different than outpatient or ASC fees, but they are determined by the payer, and they're typically, a bundled payment. If it's for a particular CPT code, what they do is they pay much less to the physician because they're making this facility payment to the facility to cover all these other things. So the work RVUs are the same.
That's dollars versus RVUs.
Yeah, so the dollars to a physician, if you do it in your office and you're self-employed or you're employed by a non-facility, an entity that is not billing facility fees, you get a lot more dollars for doing the same procedure because the dollars are covering your costs.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.